Friends,
so we are live now. We can start. Ashok,
right.
please check.
Yeah.
Well, good evening, friends. We are going to start this webinar. The topic of the webinar is emerging therapy in osteoarthritis. Can we decelerate osteoarthritis? Well, our chairman, Dr. K.D. Tiwari, is here. Both president or secretary, they are otherwise engaged in another webinar. The president is there in a webinar with British orthopedic surgeons, and secretary is also somehow busy, and he has expressed his regret that he will not be able to come here. So with the presence of IOA representatives, Dr. Ashok Syam, Dr. Samsul Huda, we have the pleasure of their company, and now we will request our chairman of this rheumatology IOA subcommittee, Dr. Tiwari, to have his words of wisdom on this osteoarthritis webinar. Dr. Tiwari, please.
Hello, everybody. Can you listen me?
Yes.
Yeah. Good evening. I welcome all the speakers, all the eminent speakers of the India. First of all, I would like to welcome our senior most speaker, Dr. S. Jha sir. And though Dr. we are missing Dr. Shiv Shankar, but wherever he is, we will be seeing the recorded message. So I welcome Dr. Shiv Shankar and Dr. Naveen Thakkar, our General Secretary. Now I welcome our other eminent.
किसकी गुजरात की बात कर गुजरात में मैं इंडियन ऑर्थोपेडिक
Yes, Dr. Thakkar.
Yeah, and
Yes.
Dr. Yogesh Amar, Dr. Shamsu Roda, Dr. Amarnath, Dr. Lakar, and Dr. Majumdar. All the eminent speakers are sitting here, and we'll be talking today about the osteoarthritis and latest therapy in the field of the osteoarthritis. So let us start our.
Thank you, Dr. Tiwari. We are happy that Dr. Naveen Thakkar, Secretary IOA, has made it possible. Dr. Naveen, Naveen, can you hear us? Dr. Naveen Thakkar. Naveen, can you hear us? Okay, I think his system is on,
but he's not.
He's muted. He's muted. Somebody can unmute him.
No, I think he's somehow engaged in such a way. Okay, fine. At least we can see our secretary there. So now I will request Dr. Hemant Chatterjee. Dr. Hemant Chatterjee, yes, your opening remarks.
Sir, good evening, all of you. My sincere wishes to our very respected Dr. Jha sir, Dr. Majumdar sir. The most importantly, this topic is definitely a great topic, and it is always useful in our day-to-day.
Yes. I think there is some problem with the internet. So
all the speakers on behalf
right.
of our committee, and wishing all the success to this meeting.
Right.
Thank you, sir.
Now Santanu Lahkar, I don't see him here. Santanu, are you there? No. Now Dr. Manish Khanna, the President Emeritus of IORA, please, your words of wisdom.
Good evening, everyone. So it's always a pleasure to have an academic discussion on various challenging topics. And now the most important topic as osteoarthritis, which is the upcoming developing, a decade was there and there was only conservative management, then we have moved to the surgical management, and now so many things, so many branches emerging in osteoarthritis. So it will be very good, and we hope that this evening will be a good discussion with the various recent aspects on osteoarthritis. Thank you so much.
Right, Professor Manish. And now comes the president of our very own association, the Indian Orthopedic Rheumatology Association, Dr. Dilip. Please,
Good evening.
please,
Thank you.
please
Thank you, sir.
have your inaugural address
Yeah.
for this webinar on osteoarthritis.
Yeah. Good evening, everybody, all the golden speakers and our emeritus president and senior most Professor Jha here, under which guidance we are actually performing this type of seminars for a long time. Actually, wonderful. This is a very wonderful association and wonderful arrangement. Awakening of the new generation orthopedic surgeon with new things that is coming up every time we are doing it. And I think that this is is an eye opener for other organizations, other subcommittees also to start this type of thing. Already they had the talk with our Shiv Shankar, our president, that he remarked that we are actually the harbinger. He told that we are the harbinger of opening up the new channels, new opening, new horizons in all the subcommittees of the country. So he had got a remark like that. So I am very happy. He will be coming tomorrow in Calcutta to do some demonstration of proprietary practice. So I hope and I pray that this is a very successful and very memorable recording. Whether Shiv Shankar will see it later on. Thank you everybody. Thank you very much. Thank you Manish, thank you Jha, thank you Chatterjee, and thank you Tiwari. Everybody, thank you.
Thank you.
So we should start it, I think, without any losing time.
Right. So thank you, Professor Dilip Mazumdar.
Yeah.
Well, President and Secretary in absentia of Indian Orthopedic Association, all the faculty members. Well, when we were planning in the very first informal meeting of the subcommittee, I had proposed that I have seen a difference in the basic concept of osteoarthritis, and this will be one of the topics. But our president said that since you are ready with seronegative spondyloarthropathy, have it as the first one. And then there was another webinar conducted by Dr. Manish Khanna. And then there was a third webinar which discussed about the different drugs, including biologics used for treatment of rheumatoid arthritis. And hence in this fourth webinar conducted by Rheumatology subcommittee, I will again re-emphasize that this is not a committee on osteoarthritis. This is a committee on Rheumatology of Indian Orthopedic Association. And so this society has felt that osteoarthritis has to be brought into focus. Friends, I must tell you that during past decade, I have traveled to all the corners of the world and all the important conferences, including ULR and ACR. And I have found it to my utter surprise that osteoarthritis has been adopted by these rheumatological societies as their own baby. And then I had an insight that what has happened, that osteoarthritis already is talked about by rheumatologists. And then I have found out that there has been a difference in the basic concept. So friends, the topic of today's webinar is emerging therapy in osteoarthritis. Can we decelerate the osteoarthritis? Friends, whatever treatment are available for osteoarthritis management, they have not been effective in either slowing the disease or arresting the disease, which could have been the best thing done. But what else can we make to allow this change to take place? Well, heart failure, each one of us is very familiar that there are many smaller issues, including blood pressure and other ailments, which may be cholesterol abnormalities, which if treated or not well treated, culminate into heart failure. Similarly, the joint with minimal symptoms can lead to a synovial joint failure. Now, what are the sequence of events taking place in osteoarthritis? There is articular cartilage surface fibrillation, which leads to osteophyte formation. There is simultaneous subchondral bone sclerosis, which is so very important. There is chronic inflammatory response. And all these are driving human osteoarthritis finally to synovial joint failure. Well, what is desirable? Desirable is that we should initiate specific therapy to forestall progression of osteoarthritis to synovial joint failure. And naturally, we pose a question: can we decelerate the osteoarthritic process? Well, friends, here itself, I would again like to deviate a little and express my gratitude to Dr. Sujit Kumar. If he's here, I would like to acknowledge his presence and his association. He is the head of the medical team of Dr. Reddy's lab, and he facilitated the preparation of teaching module for this very topic. We are very happy to have been associated with you in preparation of this teaching module. Dr. Sujit, if you are here, thank you very much. So friends, in beginning, most cases are indolent of osteoarthritis. Some symptoms, minor ones. So, but they become clinically relevant later when either non-immune or immune-mediated inflammatory events, they begin to dominate. And in osteoarthritis, what we say, rheumatoid arthritis is an autoimmune disease, but osteoarthritis is not an autoimmune disease. So there is not an immune inflammation. The million-dollar question is it an inflammatory disease? And friends, we must make it clear that osteoarthritis is itis, inflammation, and is not osteoarthrosis. Friends, if we talk about the basic understanding of the pathogenesis, the initial concept has been that osteoarthritis is a consequence of fragility of cartilage matrix. It was only in 1990s that profoundly modified this paradigm due to progress in molecular biology and discovery of inflammatory theory took place. Many soluble mediators, such as cytokines or prostaglandins, can increase the production of matrix metalloproteases by chondrocytes. But these were not being accepted till 2000. And it was only after 2000 it was acknowledged that yes, synovitis is there as a part of osteoarthritis. It is a critical feature and it is a driver of the osteoarthritic process. And very recently, the development has taken place where I said subchondral bone is so very important. It has a substantial role in OA. It has a role because it works as a mechanical damper. And friends, whenever we talk about pain in osteoarthritis, it is a source of inflammatory mediators implicated in OA pain process.
Right.
So
अच्छा,
generation of pain mainly, chiefly, not only, but chiefly can take place in the subchondral bone. And the deeper layer of the articular cartilage can get degraded because of the subchondral bone involvement. So, osteoarthritis, which was initially considered cartilage driven, is a much more complex disease of heterogeneous nature, and the inflammatory mediators are not only released by cartilage, also released by bone and synovium. Well, arguments in favor of inflammatory theory of osteoarthritis: there is low-grade inflammation which is induced by metabolic syndrome, and the metabolic syndrome is abdominal obesity, high blood pressure, high blood sugar, high serum triglyceride, and low serum HDL. There could be activation of innate immunity and also inflammaging. Now, inflammaging is age-related changes leading to low level of inflammation. So, normally, joint under healthy condition, the synovicites produce synovial fluid, which nourishes and lubricates the articular cartilage and contributes to cartilage homeostasis. Well, in osteoarthritis, Dr. Raja will tell us in detail that the synovium contributes to articular cartilage catabolism, and byproducts of breakdown of cartilage involve the extracellular matrix, which consists of fibronectin and collagen fragments. They induce inflammation in extant chondrocytes and adjacent synovium. So finally, friends, this webinar, we will have the opportunity to hear from stalwarts that the emerging new targets for therapy, will they go beyond symptomatic relief and hopefully induce slowing or stopping of the progression of the disease. Now, may I request the first speaker, Dr. Yogesh Kamath from Mangalore, who speaks on novel perspective in osteoarthritis. Dr. Yogesh, please. I will stop sharing it. Right. Dr. Yogesh? Dr. Yogesh, are you there?
Hello, sir. I am here.
Yes, please go ahead.
Yeah. I'm just sharing my screen now.
Please.
So welcome and thank you very much, Professor Jha. Greetings to everybody from Mangalore. I am a hip and knee surgeon myself here in Mangalore, and I'm privileged to be here. I will give you an introduction on the brief lines, taking ahead from what Dr. Jha just mentioned. So clearly, osteoarthritis is progressive, and we as surgeons are used to seeing it in the late stages where the cartilage has totally worn off. We also know and are taught of progression of cartilage wear from what you can see is grade 1. These are arthroscopic pictures, softening of cartilage to further decrease in thickening to exposure of the bone. We know the structure of cartilage, and our investigations are also tuned to see these structural changes. That is the MRIs and the X-rays. But what actually happens, there is a borderline between present cartilage and absent cartilage when the line for surgery is drawn. But whether there is anything which can prevent this progress is probably detection of it early before those structural changes do take place. Now, the first and foremost, when you see a patient with probable osteoarthritis is actually ruling out whether there is any other inflammatory process going on. On the left side, you just see a South Indian perspective. In the monsoon, we think that the water is flowing and it's very, very clean, but it may not always be so. So similarly, in osteoarthritis, you have to imagine that a good proportion, up to half of patients, can have predominantly inflammatory pathology. Watch out, these could be early signs of inflammatory disease. There could be many other causes which can cause secondary osteoarthritis, and these have to be taken into account before you go down and dictate treatment terms, because obviously that would influence your treatment. Arthritis in terms of osteo and rheumatoid have been thought to be diametrically apart, but on the lines of what Dr. Jha said, we know that rheumatoid arthritis as well as osteoarthritis do have flare-ups from time to time. Even though we thought that rheumatoid arthritis was predominantly inflammation, we know now that osteoarthritis also has inflammation in its origin. And we have now defined end organs. End organ damage is the same. We know that immune mediators can be present in osteoarthritis as well. Now, the joint, of course, is taught as the organ with all these components. Rheumatoid arthritis will predominantly affect the synovium, but with greater discovery of the cellular pathologies and inflammatory mediators in various parts, that is the joint fluid, the cartilage, and the inflammatory process, which eventually affects bones, our perspective and, of course, the avenues for treatment are definitely changing. So again, a South Indian perspective here. Of course, it might seem very different. Osteoarthritis is predominantly structural, whereas the other types of arthritis have an inflammatory component. But keep in mind that the behavioral pattern of this disease might change and it might affect differently at different stages. So the scope and possibilities in terms of treatment are indeed vast. The forthcoming speakers will enlighten you more on the topic, and we carry on from there. Thank you.
Right. Have you stopped sharing, Yogesh?
Yes, indeed.
Okay.
The net problem there, Yogesh, net problem.
Now, my screen is visible? No?
Yes, sir.
Yogesh, yeah.
Okay, my screen is visible?
Yes, sir. Yes, sir.
Okay. So, Yogesh, you have rightly talked about similarities between osteoarthritis and rheumatoid arthritis. So, classic cellular inflammation is not a prominent feature in osteoarthritis. Number of leukocytes in joint fluid is low in osteoarthritis, rarely exceeding 1 to 2,000 cells per ml, whereas in rheumatoid arthritis, it exceeds 2,000. Well, in synovial inflammation present, which is low inflammation, lower grade inflammation, it is present in osteoarthritis and it can be indistinguishable from rheumatoid arthritis. But there is an important difference. Macrophages are predominant in osteoarthritis, whereas T and B cells predominate in rheumatoid arthritis. In osteoarthritis, the pro-inflammatory mediator includes the cytokines and the chemokines. Well, with these words, now I can invite Dr. Dilip Mazumdar from Kolkata to speak on clinical manifestations. Dr. Dilip, please.
Yeah, thank you very much. So, actually this, are you stop sharing?
Yes.
Yeah. So, yeah. Is it seen?
Not yet.
Now?
Yes, very
It's
good.
visible.
Yeah, thank you very much for the Yogesh has enlightened us very nicely about osteoarthritis and rheumatoid arthritis. Osteoarthritis, clinical manifestation and differential diagnosis. So it's a very simplified way I have prepared it to give you some tips and tricks how to go for the clinical examination. So mechanical axis relevance for clinical features, everybody knows that the long axis deviates this way, that way, will make you the varus or the valgus. It's very simple. Everybody knows it about this thing, that how much deviation will be there for the varus, how much. So ponder fast mechanics, then mending, or fast mending, then the mechanics. It's difficult to know about that. So see, these are the cases of osteoarthritis. They usually come at the end of the journey of all treatment. As in the outset, Yogesh has told us. And you see, people come like this with the gate, and we go for the examination. So this is the way they take the support, either a crutch or the help in the hands of the assistant. So this is everybody knows about these things. I'm not going into that. Yeah. So faulty mechanics and empty measures, and thus deformity waddles to the destruction. And orthoscanogram can tells you about the coronal, but fails the sagittal, whether there is any flexion deformity or no. History of other causes, aging process, defective lubricating system. See the cause, bent at the knee, at the horizon. This is not at the not conforming to the horizon. You see, there is the obliquity. So wear and tear. What is the history? History is the obesity. Is very important to see for the obesity, and abnormal mechanical loading is there. See, they can correct the angulation by this. So clinical manifestations from known pathology to the unknown direction of all tissues around the joint. So for clinical examinations, we look at the face of the patient first. Then we look at the eyes to feel the storm inside. Begins the clinical journey when he or she walks in, inspecting the general systemic and the local changes, more or less than normal. Feel the soft tissue and the joints where it hurts. Ask to move, assist to get more or need. Measure your 3 measurements: length, girth, and the angle, to record, retrieve, and plan for a retrieve. And often then turns a doubting Thomas, confusing with the differential diagnosis. Friends, finally, the friends of the investigating tools get you to the destination to plan, play the game of treatment, and prognosticate. So what the clinical manifestation is? Attitude, torso, positioning, balance, and fitness of the patient. But at the gate changes started, when it started, orthosis, shoe, stick, splint, caliper, which is coming into your clinic. Walking distance is reduced. ADL loss, rest pain. Whether there is a rest pain or work pain, or there is a night pain, that is important. The spine, hip also will follow. Skin changes, swelling, there will be locking, deformity, low bone health under the treatment of the teriparatide or bisphosphonate. Muscle bulk and strength. Is see in the COVID situations like this, I can give you some tips. One is the Nasorma, another is the Socrates. So what is this Nasorma is? Nasorma that you write in your prescription pad, name, age, sex, occupation, residence, mode of presentation of associated disease. And Socrates is nothing but the deformity, limitations, inability, pain, and swelling and limb. So what the Socrates in short? Site, onset, character, radiation, association with others, and time of the course, exacerbating and diseasing factor, and how severe the pain is. See, the profile cannot be seen from the back. So is there any flexion deformities? Clinical features: pain, 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 and pain. Usually low onset of discomfort with gradual and intermittent increase. Pain is more on weight bearing due to the stress on the synovial membrane, as all tissues around the joint is affected, and later on due to the bone surface, which are reached with nerve endings coming in the body. So diffuse, sharp, and stabbing local pain. And see the mechanics that has been changed a lot, whether there is a horizontal translation. So these things will come with lost alignment. Patients will come like that with clinical features of pain. What are the types of pain that you face? Mechanical, then increase with the joint. Inflammatory in the phases in the beginning. Rest pain later at 50%. Night pain for 30%. So the clinical deformities you see for the soft tissue swelling, mild synovitis, remember osteoarthritis is mild synovitis, small effusion, avoidant nodes for the osteophytes and joint laxity because of the ballooning of the capsule. So asymmetrical joint restriction leading to ambulation. So what the clinical features of movement? Gaining stiffness at the period of the inactivity, 15 minutes in the early morning, stiffness, coarse capitus, palpate and here, flecked of cartilage and evernated borders. We have to the patellar grating for petrofemoral way, L5 tenderness for the lumbar spondylosis, ankle joint tenderness, and osteoarthritis, the hip by seeing the rotations of the hip. So reduced range of movement, capsular thickening, all has been muscle spasm. So what is the summary? Loop, feel, move, measure. A patient with the typical way of the knees, the normal standing posture, there is a mild varus angulation of the knee joint due to symmetrical way of the medial tibial. So what is the clinical feature to look for the examination? Valgus test, varus test for the laxity of the ligaments, Lusman test for the anterocruciate, McMurray test for the meniscus, and waddling, dark waddling for the step. So severity, stage 1, stage 2, stage 3, stage 4, minimal way changes, the minimal joint diminution, or there is a decreased joint spin, more decreased joint spin to the osteophytes, and alignment is lost in stage 4. So differential diagnosis, as you have got all the investigation to filter out whether it is osteoarthritis or something else, that we have come to a point that it is osteoarthritis. So osteoarthritis again have got 5 gradients, you see, medial pain, lateral pain, diffuse pain, and so in the medial pain there will be osteoarthritis, medial collateral ligament, meniscus, and dorsal. In the lateral there is lateral collateral ligament in the middle and the iliotibial band. In diffuse pain, anterior pain, osteoarthritis, patellofemoral syndrome, patellofemoral bursitis, and quadriceps. And in the diffuse pain is infectious arthritis, gouty arthritis, pseudogouty arthritis, rheumatoid arthritis. This has got the diffuse pain, not sharp pain, remember. And posterior pain is for the Moran-Becker system, all osteoarthritis. So as already told by our Jogesh, this monofocal, the primary way or secondary way. So this is just a glimpse of the primary way and the secondary way that everybody knows. So take home track is that where there is a smoke, there is a fire. So where there is a deformity, there is the deceleration. And see, for the bone ends that rub together, that eroded cartilage occurs in the osteoarthritis. Whereas the swollen inflamed synovial membrane in the rheumatoid arthritis. So worsens with activity, relieves with rest, whereas it is worsens with the rest and relieves with activities. Thank you very much. Thank you very much, all of you. And the osteoarthritis goes on. This is the beginning of the story of everybody's life. Thank you very much. Thank you.
Thank you, Professor Dilip.
Thank you.
Please stop sharing it.
Yeah.
Right.
Thank you.
So
Thank you, Professor Jha.
yes, you have very nicely covered that what are the source of pain. Am I visible? My screen is visible?
Yeah,
Yeah,
it is.
yeah.
Okay. So I want to right. So the reasons of pain, what happens whenever joint replacement is done, and then also the patients keep on complaining of pain. So what are the various sources of pain has been beautifully classified into anterior, posterior, medial and lateral and diffuse. So
Yeah.
the pain sources could be in osteoarthritis, the osteophytic periosteal elevation, vascular congestion of the subchondral bone. Again, I am emphasizing the subchondral area becomes so very important. There is increased intraosseous pressure. Synovitis, again, with activation of the synovial membrane nociceptors, fatigue in the muscles even can cause pain. Overall joint contracture, joint effusion and stretching of the joint capsule, torn menisci, inflammation of the periarticular bursa, periarticular muscle spasm, psychological fractures. Some patients are even conscious of the crepitus giving them some kind of pain, and the central pain sensitization again becomes very important. Well, friends, I would like to bring to your notice that, like we say, the Euler criteria for diagnosis of rheumatoid arthritis. So similarly, this criteria for classification of idiopathic osteoarthritis. And Dr. Dilip, I am very happy that while discussing with you, you said that pure idiopathic osteoarthritis is really not very common. So there are three criteria: clinical and laboratory, clinical and radiographic. Apart from knee pain, there are 6 things: age more than 50 years, stiffness of less than 30 minutes, crepitus, bony tenderness, bony enlargement, and no palpable warmth. So apart from pain, if 3 of these 6 are present, this is the clinical diagnosis, which has 95% sensitive, 69% is specific. The laboratory criteria apart from those 6 are ESR less than 40, rheumatoid factor 1:40, synovial fluid signs of osteoarthritis with a clear viscous, and as I told you earlier, WBC count is less than 2000, and radiographic changes at least, again, the osteophyte must be there. So we have to look to the diagnosis of osteoarthritis in this fashion also. Thank you. Thank you, Dr. Dilip. Now, may I invite Dr. P. Dhanasekhara Raja from Coimbatore for his talk on recent advances in etiopathogenesis and treatment. Dr. Raja.
Good afternoon, everybody. Respected Professor Jha, President of IOA and Secretary, Assistant Chairman Dr. Kamlesh Tiwari, the senior faculty. We are going to talk about the recent advances in etiopathogenesis and treatment conservation.
Excuse me, please, all others, put your mic in off position who is not talking. There is some sound coming from some mic. Right.
So you know, osteoarthritis is a whole joint disease. Previously, we thought it was only a cartilage disease. Professor Jha explained in his introduction that it could be a whole joint disease. And initially, we thought it's due to cartilage matrix breakdown. But we know now synovitis, subchondral sclerosis, and osteophyte formation and pigmented capsular contracture, everything contribute to the pathogenesis. You can see the normal cartilage on the left side, and the right side there is cartilage degeneration. There is synovitis, neoangiogenesis, subchondral sclerosis, and all these factors contribute to the pathology. So this is an osteoarthritic knee pathology. It's a sorry, so we think osteoarthritis is breakdown of the cartilage. That's not the only thing that's happening. You can see the subchondral bone provides hydration and oxygen to the cartilage. And there is a lot of inflammatory changes happening. There are cytokines released from the macrophages. Synovial fluid is decreased. Destructive proteins are released, and there is degradation of the cartilage and subchondral sclerosis. Osteophytes forms. So if you look at the etiology, there are various phenotypes which cause the osteoarthritis, not just the cartilage breakdown. So there is a different phenotype. It's a heterogeneous etiology. There is the age-driven phenotype, cartilage-driven phenotype, metabolic phenotype. It's called inflammation. Synovitis-driven phenotype, subchondral bone phenotype, and trauma-driven phenotype. Most orthopedic surgeons are familiar with the mechanical phenotype. So if there is a malalignment or loss of meniscal tissue, or there is a cartilage lesion more than 10 millimeters, or instability or trauma to the joint, it predisposed to osteoarthritis. So now we can address this malalignment or meniscal damage with the corrective surgery. We do high tibial osteotomy, meniscal repair. Now we are gone to artificial meniscus and meniscus allograft. Cartilage can be grown in the lab, and autologous cartilage can be implanted. But the basic pathology we need to address, as we know, when the cartilage is broken down, it releases a lot of metabolic enzymes, which stimulate the macrophages and the fibroblasts, that in turn causes a lot of inflammatory reaction. There is hardening of the cartilage matrix. There is subchondral bone sclerosis. There is synovitis. This again brings in a lot of inflammatory changes. And the release of cytokines accelerates the changes in the joint. So basically, it starts from because of the enzyme-mediated and cytokine release. The metabolic phenotype, where there is obesity or lifestyle-related problems, there is metabolic reprogramming. It's called inflammation, and there is cellular senescence. It's called SASP, cellular senescence-associated secretory proteins. These enzymes are released, which causes again inflammation and osteoarthritis. If you look at the mitochondrial level, the cellular level, the normal metabolism happens with glucose utilization via glycolysis and oxidative phosphorylation. But in aging and other reasons, the metabolism switch over from oxidative phosphorylation to glycolysis as the main source. So the mitochondrial metabolism is impaired. This leads to release of reactive oxygen species, which again starts inflammation. So now we move away from the traditional treatment consideration, just giving analgesics, physiotherapy, intra-articular injection, which are symptomatic relief, or finally arthroplasty. We are looking at prevention of disease progression. We're trying to attack the arthritis early and prevent progression. We're trying to have cartilage regeneration and reversal of cartilage damage. So the newer developments are targeted specifically to the particular phenotype. So, for example, we target the subchondral bone of the joint. We give biphosphonates and vitamin D so that the subchondral bone is stronger, there is no collapse. Then we target the cartilage metabolism. We give matrix metalloproteinase inhibitors, growth factors like spurfirmin, cathepsin K inhibitors, which specifically address the cartilage strength and promote regeneration. We also address inflammatory mechanisms like IL-1 inhibitors, TNF alpha inhibitors, curcuma longa extracts. These all address the inflammatory mediators like IL-6, transforming growth factor beta, all these cytokines. We also address pain pathway. We directly address the pain relief by giving specific drugs which address the pain pathway, or sometimes we use intra-articular steroids as well. So it's very important to know what phenotype the particular patient belongs to. It can be a genetic or metabolic or injury related, so that we can give personalized care for this patient. We give particular targeted therapy. So for example, if cartilage is a patient is cartilage type phenotype, we can use spurfirmin, which improves the total joint cartilage thickness. The subchondral bone is weak, we give zoledronic acid to increase the bone strength. cathepsin K inhibitor has been shown to reduce bone and cartilage degeneration. To target pain pathway by intra-articular transcapsaicin molecules. So similarly, the metabolic syndrome can be targeted by giving OX2 inhibitors and metformin. So based on these phenotypes, we can address our disease pathology. So we focus on disease progression and cartilage regeneration. Personalized therapy is important. Phenotyping of OA is very important, and there's an active research happening so that we can individually address the particular phenotype and prevent cartilage degeneration and promote regeneration. Thank you for the opportunity.
Right. Thank you, Dr. Raja. So you have talked about the phenotyping. Till now, phenotyping was not being practiced, and Del Isola was the person who talked about phenotyping. So can you tell us that how phenotyping helps us in finally management of the individual patient?
So we have seen a lot of similarity between osteoarthritis pathology and rheumatoid arthritis pathology. So in rheumatoid, we are able to address the specific target like tumor necrosis factor alpha. So if we are able to target that, we are able to stop the progression and sometimes reverse the progression. In osteoarthritis, there is no particular marker in disease progression or initiation, but there are particular subsets like metabolic phenotype. The patient with obese, patient with adiposity, they have metabolic phenotype. They release SASP, senescence associated secretory proteins. And there are groups like where cartilage is at defect, and there are post-trauma induced phenotypes. So there are different phenotypes, genetic phenotypes. We're able to particularly target that type of phenotype. Like you want to target the cartilage, we can have specific drugs to target the cartilage. You want to target the subchondral bone, we can target that particular target. So for senescence, there are anti-senescence drugs. So we can target pain pathway. We can target synovium separately. So there are different pathways which we can target. So if you're able to identify that phenotype, we are able to develop drugs to target this target, and we can slow progression.
Right. Thank you. So as you can see in this chart also, it identifies individuals at higher risk of progression. It identifies patients more likely to benefit from a particular treatment approach, identifies specific pathological processes for targeted treatment, and identifies the disease targets to develop new agents, treatment, and strategies. Well, I here would like to talk about a particular CX43. This is increased production of CX43 in the synovium and articular cartilage chondrocytes take place. This is very important. Whenever we want to study that this particular osteoarthritis is more active or has become less active with treatment, the assessment of CX43 becomes very important, and it is related with it that CX1 and CX2 urine analysis tests are available there. Well, concomitantly, various MMPs, including specifically MMP13, can be seen, and MMP13 inhibitors, they have been used in the management of osteoarthritis. Well, talking about gut microbe, they are also involved in osteoarthritis pathology by modulating the pro-inflammatory cytokine IL-17 activity. The potential therapy, regulation of the gut microflora in high IL-17 expression subgroup of OA patients. So IL-17 is the key cytokine which can modulate the gut microbes. So this also has to be kept in, could be taken care of. Now, may I call upon Dr. S.S. Amarnath from Bangalore, who speaks on classification, investigation, and imaging. Dr. Amarnath, please. Dr. Amarnath, are you there? Yes.
Yeah, I'm there, Dr. Jha. If you're able to allow me to share the screen, please.
Sure. Oh, sorry.
Dr. Jha, one point you should tell later on.
Right.
Later on, one point you tell about the subchondral bone vascularity.
Okay.
Right. Yeah, I think, are you people able to see my screen?
No,
Not yet.
Not yet. Yeah.
Yes.
Yeah, now
It's come on. Okay, wonderful. Now, thank you, Dr. Jha. Thank you, Dr. Manish, thank you, Dr. Dilip and Dr. Tiwari, Shiva, and obviously, Naveen, for giving us the opportunity to share our thoughts. 6 minutes is not sufficient. In fact, 6 hours is not sufficient. In fact, 6 days is also not sufficient to talk about osteoarthritis. It is such a vast subject. And keeping that in mind, today we are talking osteoarthritis on classification, investigation, and imaging in between the ongoing challenges that we all face in the world and we are facing. A lot of things are going to be a part of our therapy, the part of our investigation, the part of our treatment protocol that we can talk about. And with this in mind, I hope and everybody is immune or at least vaccinated, and we take it forward. Osteoarthritis, coming to classification, I think Yogesh, Dilip, and Raja has given a beautiful narration on how, where, what, and a lot of things have been going to be in and out of, what shall I say is similarity will be there in the slides or probably the subject, some of them. So hence, I would definitely take a key point here to make sure that we will look at the symptoms and how do we classify and how do we take it forward. Keeping that in mind, I mean, obviously we all know that we have different variety of deformities coming in. So we need to make sure we don't get there. That is the biggest issue. That is the biggest criteria for all of us to make sure. Keep it early, pick it up early so that we can, avoid these challenges. In the classification, I think briefly mentioned earlier on by Dr. Dilip, we have pathological and radiologically we can classify. Now, coming to pathologically, we can talk about primary and also secondary. So, points have been touched upon by all the 3 speakers. I'll just run across few things what can be a part of our ongoing issues that is going to be majorly affecting us, because that is a key factor for us. We need to treat the condition where we are coming from, not just the symptom of pain. Yeah, pain relief is the main thing, agreed. And inflammation control is the biggest thing, but we need to be very clear as to where and how we can talk about it. So the time is running out, and obviously I'm going to be running through this entire number of slides. While grading, we have different variety of deformity coming in because of the degeneration happening in a different region. So let us classify from 0 to 1 kind of a grade in radiological talking. The best classification has been taken, and there are a lot of classifications. I will not run through that, but one example to talk about is the KL, or probably the Kelvin-Lawrence. We all know that grade 1 to grade, or probably you can talk it as grade 0, which could be the normal one, So there are 5 grades of arthritis, or the knee grading can be done. And that definitely makes a point for us to take it forward in terms of our, treatment and what stage they come in and how we can treat further and also predict the kind of treatment that we can talk about it. Coming to the hematology or the blood investigations, there are quite a few things that we need to talk about it. So let me talk starting with hematology and serology. Now, as a patient comes in, clinical examination. In fact, the biggest thing is history. History and clinical examination gives us almost 90 to 95% of our diagnosis, they say. But today, we are not just talking about just that. You and I know that. Today we are practicing legal medicine. So you need to substantiate and make sure that patient gets the right kind of systematic way of approach so that he or she gets the better pain relief and quality of life at whatever age they come in from. Mind you, osteoarthritis is coming in very early now, not just old age. It is not a symptom of old age anymore. So that's the biggest challenge. Depending on the kind of patient, either a male or a female, there are certain tests that we need to include. These are by and large, we need to include in our investigations. Very, very important, because this plays a very important role in differentiating the secondary causes and the treatment protocol that can be taken forward. So keeping that in mind, the biggest thing, Dr. Dilip mentioned about the softening of the bone. Yeah, osteoporosis is the biggest thing. And there's a spelling mistake here. I'm sorry about that. It's biomarkers. Pardon me for that. And then we talk about the synovial fluid. It's a big effusion comes into the joint, and then what happens? We aspirate and throw it in the bin. Mind you, it's so important for us to take it, get a serum, synovial fluid analysis made, examination made microscopically, physically, and we need to look at the culture and sensitivity if there's an infection, if there's a crystal arthropathy coming in. A lot of things are there, very, very important factors that need to be kept in mind. So these are some pointers that we keep in the radiological investigations. What do we talk about? I think it's been done already, but the modalities are very, very good ones. The basic X-ray, right from the time of Roentgen's invention. Today we talk about get a standing AP. Classically, every radiology technician makes the patient lie on the table and get the AP lateral. It's fine if the patient is not able to or differently able, or if there is any issues. But by and large, we need to get this because we need to see a lot of alignment from the hip joint, pelvis, in fact, pelvis to down the knee to ankle. So very, very important. And then to talk about, we also have, in the tier 1 and tier 2 cities where they may not have an access for a lot of higher investigations, Skyline makes a big, big importance. Scanogram again is limited to the digital X-ray, units throughout the country. So that is one. Ultrasonography is one of the biggest musculoskeletal, radio diagnosis tool that has come in the recent past. In fact, orthopedic surgeons are also getting a training done there. Sports medicine, people are getting trained under that. And then it's a very important tool. We don't need to get really worked up. And if you're not, you can refer them, but you need to have a good hand of ultrasonography. CT scan is a major important thing. MRI, no doubt about it. Yes, bone density makes a big, big impact. Scanogram, we need to see the alignment of the bone, basically, so that we can plan our treatment accordingly. Then comes our, the grading comes into picture, different pictures, different stages. Is it mono or unicondyle or bicondyle, and tri-compartmental? All those challenges we've seen this in time and again. We go on and on these things. So when you follow up a patient, you could see the progress happening. You could have prevented, or probably kind of thing. That's one of the biggest things that we talk about. Now, coming to ultrasonography, you need to have an orientation. Where is the probe? How you are interpreting each and every structure that we're going to see and scan it. So keeping that in mind, what are we talking about? There could be a probe which is coming in, and then you're screening from anterior posteriorly. How do we see the structure? That is very important for us. There's not the time to class to give a detail, but this is just to give you a bird's eye view of investigation. When you do it on the medial side, you could see an image differently again. That has to be interpreted the way we can scan it. Very important. And again, mind you, it is not just radiological classification. We also have ultrasonological classification of the osteoarthritis in the knee joint. Very important. I'll not take the time. Now, CT scans, very important, because there are a lot of other structures which may not be picked up in the X-ray. We need to rule out and make sure that is happening. And then see, that is the biggest challenge now. Osteochondritis happening here, and chondromatosis happening, and so many issues the joint may have. We may miss out in the radiology, the common simple X-ray. So that is important for us. But that doesn't end the show there, because we need to see the soft tissues as well. And then how is the damage happening in the soft tissues? That gives us the clarity the biggest tool that each of us can think about is MRI. So very important for us. There's MRI grading of the osteoarthritis is another classification coming in. I don't want to confuse you with too many classifications, but yes, MRI makes a big thing. And again, MRI can be plain MRI. Also, we could have with contrast. Here we talk about a proton density weighted, or that is actually a T1 or T2 images can be done. And if necessary, in the past, we did what is called an arthrogram, where we used to inject a dye. Today, it's history. We don't even do that. So today, we can do that with a simple dye injected into your vein, and then everything is taken care. So very, very important for us, because the treatment lies in a massive way in the kind of staging. So with this, I give my short bird's eye view of investigation, classification, and imaging in osteoarthritis. Thank you.
Thank you, Professor Amarnath. So you have been excellent under the time constraints that you had. But in the meantime, Professor Dilip wanted me to tell something about the vascularity of the subchondral bone. Well, Professor Dilip,
Yeah.
as we say, it is a low-grade inflammation, and the subchondral bony area gets more blood supply, and since there is more blood supply, there is congestion, and that could be a cause of pain, number one. Number two, gradually the subchondral bony sclerosis takes place, and it is observed by some persons that this may be the only feature, only the first radiological feature visible, but other set of persons feel no, subchondral bony sclerosis can be seen only in the later stage. So whatever it is, initial hypervascularity, local engorgement of blood vessels, production of pain, and then subchondral bone sclerosis is the chain of events taking place at the subchondral bony level. Now, Dr. Amarnath, you have very rightly said that imaging becomes so very important, and visualization of OA features can be seen in the ordinary röntgenogram. But additional imaging, as you have already detailed, MRI, ultrasound, they can see the synovial hypertrophy, synovitis, and cortical erosions. You talked about traditional MRI, but there is also functional MRI, which detects biochemical changes in the cartilage. Did you talk about it, Dr. Amarnath?
No.
Right. And there is something else known as compositional MRI. This compositional MRI evaluates biochemical properties of the tissues, and it has the ability to assess pre-morphologic biochemical changes of the articular cartilage and also in tissues in and around the joints. Then there is a hybrid PET and MRI combination, and MR cartogram becomes very, very important when you want to see the depth of the articular cartilage. Contrast enhanced MRI, well, in pain phenotypic patients, synovitis, bone marrow lesions, and meniscal abnormality could be seen. Well, in MR cartogram, we can assess the depth of the articular cartilage. Well, another important highlight that I would like to make, that biomarkers become so very important when we are trying to evaluate that this particular therapy has become effective or not. And then these biomarkers, three things become very important: serum, comp, urinary CTX2. I had talked about urinary CTX2 and the serum hyaluronic acid. Now, serum comp is cartilage oligometric matrix protein, and this is a specific serological marker which is present in the synovial fluid and also in the blood, because when the cartilage disintegrates, this is the biomarker which you can assess either in the synovial fluid or there in the blood as well. Urinary CTX2 I have already enumerated, and similarly hyaluronic acid also help in assessment. Now, without wasting any time, I would request Professor Abhay Elhens, who will be talking about treatment algorithm, NSAID, most importantly DMOADs, development of personalized therapeutics also. Professor Elhens, your time starts now.
Thank you, sir. Can I
Right.
share screen?
Yes, just a second, right.
Yeah, at the outset, my extreme gratitude to Professor Jha, to Dr. Manish, and to Professor Majumdar. Is my screen visible?
Yes.
Yeah.
Yeah. So just to start on, when we talk about personalized medicine, it is like the new shirt that I want to wear. And when we talk about personalized therapy for osteoarthritis, we need to understand where we are coming from. And essentially what that means is that the disease pathogenesis of OA is not fully understood. The central hallmark of disease is that it is slow, it is chronic, and shows progressive destruction. The disease, however, has shown that it involves predominantly the bone, cartilage, and the synovium, with a lot of interest lately in the cartilage. And the current treatment options of osteoarthritis vary from pain relief to improvement of function. And therefore, the non-steroidal anti-inflammatory drugs, the intra-articular steroids and hyaluronic acid injections have very little effect on actual structural degradation of the joint, and these patients eventually land up into reconstructive surgery in the form of total knee arthroplasty. So the non-steroidal anti-inflammatory drugs, as I've already said, there is no role of a single agent like paracetamol. The pain relief can happen with drugs like diclofenac to a drug dose of about 150 milligrams per day. And one has to be careful about certain renal parameters which can get damaged and distorted. And this is a very, very interesting graph. And this is basically the reason why the world is talking about targeted strategies for osteoarthritis. So till such time, the cartilage, the joint cartilage, does not show a full thickness volume loss, even to the stage when the cartilage has had a focal thickness loss, one can get the cartilage to regenerate. And that is essentially, basically across the globe, causing scientists to study the mechanisms of damage as well as study the personalized therapies leading to regeneration. And what basically is the hallmark of this period of growth is a branch of medicine called precision medicine, which essentially, as has already been talked about by Dr. Raja and even Professor Majumdar and Dr. Jha alluded to this. One has to identify that osteoarthritis is not the common mechanical degenerative osteoarthritis of the knee or the hip or the hands, but it consists of certain primary and secondary phenotypes. And it consists of certain age-related and systemic and inflammatory phenotypes, certain intra-articular and extra-articular phenotypes. And what these phenotypes do, and that, as Dr. Jha was just talking to us about, is that the window of opportunity opens up essentially because each one of these phenotypes have a quantifiable measure of certain very specific neurochemicals in the synovial fluid, in the blood, or in the urine. And that is the reason and the focus of where and how targeted therapies can be accommodated and can be focused upon. to an extent that people have actually come out with something which is called a B score, which is like equivalent to a T score of a DEXA scan, which is used for quantifying the degree of osteoporosis. So the degree of targeted therapy or stratification of drug therapy for osteoarthritis also, according to certain scientists, can be focused and scored. Now, what should precision medicine include? Essentially, it should include identification of the basis for personalization, a reduction of risk factors, targeted therapies, and personalized realignment procedures. And the bulk of these drugs essentially cause prevention of cartilage breakdown and promotion of cartilage repair. They are targeted at the synovial inflammation in osteoarthritis, as has already been discussed beautifully, and they are targeted at the subchondral bone remodeling in osteoarthritis. So a lot is being done just basically to make sure that we do not land up into the end stage disease treatment in the form of arthroplasty or realignment osteotomies, but for certain targeted therapies. And one of the most important ones of these are the metallic metalloprotease inhibitors. And these MMPs, as we understand, are essentially drugs, are essentially chemicals which are present in the articulochondrocytes. The beauty of MMPs is that it has a dual role in the joint. It is involved in pathological destruction of tissue as well as in remodeling and repair. And the drugs which are focused at inhibition of MMPs actually not only cause a stoppage of the pathological destruction, but also sometimes can play around with the repair function of these MMPs. And there has been a beautiful trial and the most talked about drug PG116800, a matrix metalloproteinase inhibitor. What has come to light about this drug following a 1-year dose response study is that after the usage of the prescribed dose of this study, there has been no change in the joint space narrowing or the functional outcome scores in patients of osteoarthritic study, as said a double-blind placebo-controlled trial. Coming to bisphosphonates, well, the focus of these drugs is in working on the loss of structural integrity in the subchondral bone compartment. And these are anti-resorptive drugs, which essentially are osteoclastic inhibiting factors. And most of the studies has been done on risedronate through 2 fantastic trials. One of them is a COSTARS trial, but both these trials, after a 1 and a 2 years follow-up, has shown that at all doses of risedronate, there has been absolutely no improvement in the functional outcome scores, and the drug did not radiographically prevent disease progression. Coming to cytokine inhibitors, there are various types of cytokines, as Professor Jha also beautifully alluded to, and these are expressed by cartilage and by the surrounding tissue and have a major role to play in the development of osteoarthritis. So starting from interleukin 1 to interleukin 17, as Sir very nicely told us, there are numerous drugs which have been known and through numerous pathways including TIMPs and NOS, which have been studied and worked on to see if they actually help in any kind of stoppage of the progression of osteoarthritis. Calcitonin, a drug with a 3 decade of usage for osteoporosis, has been recently reported to have been studied on the cartilage component of osteoarthritis. And this drug essentially has been studied in a phase 3 placebo-controlled trial and has been shown not to have too good an effect on the progression of disease or its ability to prevent the radiographic progression of the disease. There are other drugs such as HCT12 3012, which is essentially a derivative of naproxen and has been known basically as a COX-2 inhibiting drug working through the nitric oxide pathway. But this too has, despite certain trials, is in development and has not shown any confirmed positive role in the inhibition of progression of osteoarthritis by drug therapy. Coming to doxycycline, an antibiotic, which was worked on, and there have been a study on 431 women, and was reported that the joint space narrowing was reduced in obese women by 33% after 30 months of treatment. But this particular study was a relatively small sample size with a very small follow-up, and this drug could not be recommended as a chondroprotective drug, despite this the good results of this particular study. Coming to drugs like dicerine and glucosamine. So these drugs have recently had a renewed interest following certain additional roles. And these were essentially drugs which were interleukin-1 inhibitors. And essentially what has been observed is that even though there was a statistically significant benefit of these drugs on cartilage degradation and damage, the ultimate role in protection of disease and progression of disease has not been documented and has not been strongly verified. Coming to cell-based therapies, so that is a focus of a lot of research as of today. And the basic stem cells which have been focused on for the research is mesenchymal stem cells, embryonic stem cells, pluripotent stem cells, and the adult stem cells. But what has been observed is that all cell-based therapies which have been used for treatment of osteoarthritis lack standardization with respect to the qualitative and the quantitative characterization of the methods used for cell harvesting, processing, and transplantation of the cell back to the source, which is the patient. And thus, the well-conducted randomized clinical trials, despite their very well thought of research methodology, have been found to be inconclusive, particularly in their ability to demonstrate efficacy with disease-modifying results. So in the end, we come back to what we understand and know, and the take-home is that if you study the osteoarthritis patterns of hip, knee, and the hand, what we know very strongly is that there are certain established therapies which are basically very well known for prevention of pain induced by the osteoarthritis, and certain physical therapies which help in preventing or delaying the progression of disease. But if you see there has been a lot of focus and emphasis on research on the new medical and the therapeutic drug modalities involved in osteoarthritis, but their actual role in progression of disease and protection and prevention of radiographic progression of disease is still to be verified, and it is still to reach a point where they can become a standard of care for patients of osteoarthritis. So thank you for your time, and back to you, Professor Jha.
Right. So Professor Elhans, you have talked about extensively about various DMOADs. DMOADs or DMODs. And I think the focus of the management is should be both on bone and articular cartilage. So there has been a renewed interest, as you have rightly said, on calcitonin and bisphosphonate. It works at both the levels. Do you have any more comment to make?
Sir, there has been a lot of interest, and there has been statistically significant development also in the researches. But these researches and these findings are yet to reach a point in time where we can categorically say that they prevent progression of osteoarthritis. So we actually do not know whether they help in delaying the progression of disease, or they can actually prevent the progression of disease, which again, it is a it is a step in the treatment of osteoarthritis, but in the end, we are still short of drugs which can help progression of disease and avoidance of the surgical options of end-stage osteoarthritis.
Right. So definitely you have said search is still on, and there are, I'm happy to say, phase 2 trials. Some of the drugs are on phase 2 trials. Well, you have talked about them. MMP13 inhibitors are very important, and there are chances that it will prove out to be one of the illuminating drugs to come in future. Well, inhibitors of inducible nitric oxide synthetase also is in focus, and personalized treatment, you have already said, is so very important, and hopefully in times to come there will be personalized therapy available for each individual or at least a group of patients. Thank you very much, Professor Elhans.
Thank you,
and
sir.
Now I invite once again Dr. Yogesh Kamath from Mangalore, who speaks on exercise therapy and viscose supplementation. Dr. Yogesh, please.
Thank you very much again, sir. Greetings again from Bangalore. I'm just waiting to share the screen.
Please.
And yes, I have done it now. I am going to talk for the next few minutes on exercise therapy and injections in osteoarthritis, particularly viscose supplementation. Now, we have talked about progression of structural damage in cartilage, and we have talked about some certain drugs which might prevent this so far. But we now come to the stage where if some structural damage has already happened, then what? So these terms have been vaguely referred to as early osteoarthritis in the literature, and vague knee pain has often been described as chondromalacia. So chondromalacia is when the surgeon does not really know what the structural changes, but the patient has problems. A more appropriate term which has emerged and which more scientifically describes early cartilage pathology is chondropathy. So with the emergence of cartilage scanning MRIs, we now very well define chondropathy and would not refer to anything as chondromalacia, because chondromalacia would signify that the surgeon doesn't know what's happening. Now, of course, again, we still can do other therapies apart from medical therapy before the structural changes come up. And indeed, the evidence has been in exercise treatment. Now, you might consider exercises in the form of physiotherapy, particular exercise which people assume with sports or at the gym, and people are also advised limitation of certain activities, modification of some other things, and so on and so forth. Now, all of these things work if they are done in the right perspective. What clearly doesn't work or has very less compliance is use of braces in the long run, because these braces really would only work as pressure and lead to muscle wasting. I must mention yoga and early naturopathies, which have taken origin in our country, and with the acceptance of one of our colleagues, Professor John Ebenezer, as an awardee at national level, this has actually even been recognized and put forth in the AAOS recommendations. We should hence be proud here. Now, in terms of exercise therapy, a lot more new treatments are emerging, and we ourselves in Mangalore are researching this particular one, where we make a patient stand on a force plate. These are people who documented early osteoarthritis, and we see a measure of their proprioception. That is a plot of their center of pressure, which the force plate plots over a 30-second period, and variance of that suggests that their proprioception is bad. Tackling proprioception at an early stage is known to be actually helping them better. And that's what we've actually devised an algorithm algorithm and got a prize at a innovation conference at India level. Anyway, so there is also role of traditional medicine. There are various kinds of chondroprotectives which are not available, and I won't go too much into the details of this. But along with that, there are known and rightly popularized different injections treatment in the knee. Now, classical and time-tested is steroid, which works well in inflammatory flare-ups. And what I'm going to talk about today is hyaluronic acid. There's, of course, the new kid on the block, which is PRP, and that will be touched upon by my colleague later. So hyaluronic acid is actually a component of the synovial fluid. What we are trying by means of the injection is basically trying to restore the balance, give it some better lubrication, and we also know that it probably works in anti-inflammatory as well as nociceptive modes. Now, there might not be a lot of evidence. The evidence here is basically that the drug is safe to use. However, it has not been recommended by the international societies. Now, despite this, there are various indications in patients who desire to delay operations, who would rather have some intervention, actually find popular usage for this particular thing, even though it may not find acceptance in many insurance companies across the world. The important thing to note here is it is not just recommendations, but if it helps patients, and it does help a large number of patients, as long as you do it safely, it does have a role. And the side effect profile really is minimal. It can be used very much on its own. It can be used in combination with steroid or in combination with PRP, especially to reduce the inflammatory effects related to the white cell components when we put PRP in the knee. So PRP on its own can sometimes create a septic arthritis type of reaction, whereas HA addition will actually prevent that. And HA also acts as adjuvant therapy and as a substrate when cell therapy and cartilage regeneration is done. So there's multiple usage there. The theory in different types of HA, this is a busy slide, but just to drive home the fact that there are many preparations available out there. What has, if I had to summarize that, there are ones which are AV, of course, very popular, and the newer ones which are essentially recombinant DNA technology from microbial sources. These newer ones would have a lesser side effect profile because they are not proteinergic. Now, the higher molecular weight ones are known to be better in terms of longer lasting. The earlier lower molecular weight ones had to be repeated and are therefore going out of vogue because repeat interventions would put a knee prone to development of infection. However, with adjuvant treatments, one would have to go the science says with evidence that low molecular weight goes better as adjuvant when you use it in combination with PRP. So that's in a nutshell about these two exercises. I will pass on the stage back to Dr. Jha and be happy to answer questions later on this. Thank you very much.
Right. Thank you, Dr. Jogesh. One thing that exercise was included. Now, invariably, the patients keep on asking that, doctor, am I allowed to run or walk? So what is the evidence-based answer to this particular question?
So evidence-based here clearly is that running would create more impact. Now, also they ask about sitting down on the floor and things like that. So if somebody has documented mechanical wear in their knees, we know that impact-related exercises could increase that pain and over time fasten their wear and tear. So what we would advise is it's not that they cannot exercise, they can get their aerobic exercise by relative non-contact exercises, which are particularly cycling and running on, or rather exercising on a cross trainer rather than on a treadmill. We also have to include addition of supplements like orthotics, which reduce the impact in early cartilage wear. I hope that kind of specifically answers
Right. I
your
think
question, Dr. Jha. Apart from that, it is very important to institute specific quadriceps strengthening exercises because that shares the impact of the knee.
Right. And brisk walking is safe, and you can allow your patients to
Yes,
go for brisk walk.
Yes,
one
provided the ground is not irregular and provided they're not doing up and down slope. It is down slope which gives the highest impact on the knee. Up slope is relatively okay. So if somebody, the common notion is to go take the lift when they're going upstairs and come down the stairs running. Actually, it should be the opposite. Up the stairs is better for the knees. Up the stairs is better for the heart. Downstairs, it is more impact on the knees. So you should take the lift coming downstairs.
Right.
So, Jogesh, 2 points.
Yes,
Number 1, open chain, closed chain exercise.
Yes.
Number two, different colors of band of rubber bands are there that assist in the developing the tone of the muscles.
Yes.
So these two you have to please clarify.
Yes. Would you like me to talk more in detail about it? So,
outline.
Yeah,
briefly.
In a person who has more pain, it is difficult to institute closed chain immediately. Now, a closed chain helps particularly to develop a good feedback and develop a good gait. So closed chain is when the ground reaction force is acting, when we do exercises standing and we institute squats, that is half squats particularly. Open chain is sitting at the gym pushing up weight with no ground reaction force. Open chain is usually instituted first because it can help relieve pain better. But in terms of getting the patient back to activity, closed chain can later be instituted. It has to be done when the inflammation scenario is a little lesser and at a right combination for a regular exercise. It has got to be a good combination of open and closed chain.
Right. So I just want to bring to your notice that there is a Euro-Visco group study which have followed up their patients with visco supplementation for 6 to 12 months, and they had significant improvement. Now, they have classified that 4 different case scenario post-visco supplementation can be there. Number 1, patient remains symptom-free. Second, remains minimally symptomatic, but with no increasing pain. Number 3, minimally symptomatic, but with increasing pain. And number 4, patient becomes symptomatic again. So, are you aware of such results following visco supplementation?
Sir, there have been studies published. This is actually a larger group, multicentric study, which is nice. But essentially, the studies which have been available so far have been more with intervention of the companies themselves. Genzyme, which was the main marketer of this brand, has invested in a lot of trials which have shown, you can say, up to level 2 evidence with use and some improvement of symptoms. The other people would probably slag it off as circumstantial because these were done in specific centers. They have shown improvement of scores and things like that. Because it is not standardized and accepted overall, that's probably one of the reasons we've not got, overall acceptance, wide acceptance by the association, so to say. But
right, Dr. Amarnath wants to draw a point.
Yes.
Thank you, Dr. Jha. In fact, you talked about the Euro-Visco supplementation study, Dr. Jha. And then Yogesh, yes, I agree with you. I was a part of, I was a prior, principal investigator for the study which was done in India, which is called as OSS. And we followed up for about 24 to 48 months. And Level 2, I think I would definitely say 84% of, which is similar to the Euro, Visco, we came out 4 years and 5 years, almost 60 months. 84%, 84% of the patients who had the injections were 400 odd patients were picked up in 22 centers in India. And it was a multi-centric study. But yeah, the last sentence, what he said, I agree with you, because being promoted by the parent organization which did the research, so that's where the whole key factor came into low key. So that's where the acceptance level were questioned. But definitely there are a lot of studies. I think a lot of needs to be done, and then I think we have a very good scope. Probably post pandemic now.
Right. Thank you, Professor.
Sir, can I have one?
Yes, sure, sure. Please.
Sir, good evening, sir. This is Dr. Keshkar from Calcutta. Sir, we are the regular user of this Visco supplementers, and we are in the high molecular weight, hydroquinone, Synvis 1. So the results are quite encouraging, sir. Particularly in early osteoarthritis, it works well. And since last 3 years, we have used more than 500 cases and results are quite encouraging. Particularly even in grade 2, up to grade 2, they are KL grade 2, they are saying one can use, but since it is freely available, so just to delay the TKR, total knee replacement, we are using even in grade 2 plus, or you can say grade 3, there also it works well. So results are quite encouraging.
Yes, your experiences are most welcome. And now, friends, we have a subject of which we do possess a master presenter, Professor Manish Khanna. Professor Manish Khanna is not only an orthopedic surgeon, as all of us know, he is the founder also of the Indian Orthopedic Rheumatology Association as the initial secretary, and now he is the president emeritus. He has in-depth study and knowledge of stem cell study, and so he is the fittest person in this group, not only this group, rather amongst the orthopedic community, who can speak with authority on potential cell therapies. So Professor Manish Khanna speaks on upcoming potential cell therapies.
Thank you so much, sir. Sir, please allow the slide to be shown.
Okay, I'm sorry. Yes, you are here.
Yeah, I'm visible.
You are visible. Your slide will become visible.
Thank you so much. Thank you so much, sir, for the introduction. So we are going to see in coming 7-8 minutes some of the slides which will very well clearly define so many questions which have been discussed on this forum for the last half an hour, like the walking and different patterns. So without wasting time, let me start the thing. So definitely we are here for the evolution, supporting the evolution rather, as I've already mentioned initially. Now it is an era for definitely a joint replacement is there for a very damaged knee. But with the so many DMODs and different options, regenerative science is always a good option, and till now we are not able to reach to any consensus. And I think osteoarthritis is the most complex situation. It's different from the rheumatoid arthritis because of a different mechanism. For understanding the cellular therapy requirement, we need to see what is the current scenario, what we want to address actually, and how we can go ahead regarding this. So definitely osteoarthritis, there's so many causes. It was very wonderfully discussed this evening. But the most important, I'm just taking it with the laxity, with the age degeneration, and the laxity of the surrounding muscles. So it has already been discussed beautifully that how the fibrillation and the degeneration start, and we have to take a call at that particular time if we are not going to go for a arthroplasty. And definitely osteoarthritis has got a bumpy road. So many times the people are coming to us, coming to everybody, and they get resolved at early stage, and then they again have a bumpy road and they again come back to a different orthopedic surgeon. Cellular therapy is an answer, may reverse the arthritis, but to a certain extent only. So definitely that extent we all can understand. That is the grade 1 to early stages of arthritis, which is was again very well explained this evening. So, what are the difficulties which we require to find out an answer for the cellular therapy? So, it is like a surgical intervention which is not appropriate. A borderline case as a patient who is coming to us with a grade 2 early arthritis, which is going to progress, not responding to the conventional management. Of course, it has to be very well taken care of. It is osteoarthritis. We are not entering into the CPPD type of a picture, which is again a mixed picture, which we have to identify as orthopedic surgeon so as to make a clear-cut diagnosis. And in India, we are again approximately 16,000 orthopedic surgeon. So you can see and we can estimate how much complex this diagnosis is being made by us most of the time, which is not a osteoarthritis, and we think it is as a osteoarthritis. So
Anish,
definitely with
we are not
significant.
able to see a screen.
Is it?
Yeah. For the last, since you started talking, we haven't seen the screen. I'm sure others
not
still accept.
moving. Slides are not moving.
We are not seeing nor the slides are moving. I don't know why. You can stop to share and share again.
Yeah, please. So kind of you just told me just now. Just a second.
Sister?
Dr. Jha.
Yes.
So yeah, for this reason, I tried 3 times,
Right. No, I think it can get rectified. Yes.
Yeah. Very nice.
Now you are here.
Yeah, very good, Monish.
Oh my God. I'm so sorry for this. Anyways.
No problem. Please continue.
So definitely when the patient is of young age and a long duration is being seen and we know that it is osteoarthritis and patient is not able to be managed by other disease modifying osteoarthritic drug, then definitely this is a choice. Now we are discussing since evening about the cartilage regeneration and ultimately what the patient want from us. And what the patient want from us is definitely at that particular time the anti-inflammatory, the pain-killing effect without any NSAIDs and all the things, which is now a past thing actually. For moving this, definitely the cartilage repair, which has been evolved for the last 2 decades, is microstimulation. I'm not going to detail. Autologous chondrocyte implantation, we all know this thing. And latest is oats, but again, it has got certain disadvantages sometimes, as it has been seen that the long-lasting result in some cases has not been there. So for this, later on, the addition of the MNC cocktail or mesenchymal stem cell would give a better result. Now, we have already seen at different forums about what are the stem cells, but just to make it very short, we are discussing as an orthopedic surgeon the mesenchymal stem cells, which are present at all the places in the body, at each and every tissue in the body. And the tissue discussing this evening is the knee, the articular cartilage, the subchondral bone, which we are discussing since evening, that how the changes are been there, what we can do for the articular cartilage, what we can do for the subchondral bone, so as to minimize this thing to go in. So these locations are having a progenitor cells. Now progenitor cells can be classified again into hematopoietic and mesenchymal, which we are discussing this evening. Now the different modalities of the cellular therapy which are there in the clinical trials across the globe are PRP, bone marrow cocktail, that is the bone marrow being aspirated out, centrifuge, and the cocktail is being ready. and the mesenchymal stem cell, which is again a questionable, as with the ICMR guidelines, it is a cultured cell, so it should not be used unless until the clinical trials are being done. So need to understand why and when should be used. There are so many supportive literature if you Google around it, the mesenchymal stem cells or the BMAC or the PRP with or without hyaluronic acid. But definitely from India, we don't have so much work till now, but definitely the clinical trials which are moving across the globe, there are so many of them. I'm so sorry for the busy slide, but definitely only one clinical trial is being done in our country till date with the giving of a commercial product for the mesenchymal stem cell. However, the Japan, this Food and Drug Administration from the Korea, they are into the market since 2012 with the mesenchymal stem cells. But in our country, only last year we are able to come out. But again, it has been FDA approved, and it's again a conflict of a work between the ICMR and different things which should not be commented at this juncture. But as an orthopedic surgeon, I think in the coming 3-4 slides, all the answers will be there that what we can do for the knee and what our forefathers, our professors, our seniors used to do when there was nothing available for the osteoarthritis. We are discussing for this is only for the mild to moderate cases, definitely not for the severe cases. Now, after skeletal maturity, we all know that articular cartilage stop proliferating and is slow to replace as well. The reason behind is number one, the lack of blood supply. Number two, the chondrocyte which are there, they are actually very less mobile because it is in the matrix, which is very dense, and the limited number of the progenitor cells. So they are the three things which needed to be addressed for managing any mild to moderate osteoarthritic cases. Definitely, we know that there is apoptosis, there is eating up of chondrocytes with the age. Everything's advances, everything goes away with the age. So the chondrocytes also goes away with the age. So we need to replace them. So definitely a balance of the chondrocyte to maintain the matrix between the synthesis and degradation is being disturbed, and that is why the patient is coming to us. So by now we are very much clear whatever we want to do, we have to do only at the cartilage level because the next would be the subchondral bone which is to be involved. That means the cartilage is being involved first, then the subchondral bone at the most of the time. Now, active chondrocyte, how we can have these active chondrocyte at the place? Definitely by having all those chondroprogenitor cells which are there in the chondrocytes to become active. How they can become active? Of course, one answer would be a walking, which I'm going to stress later on. Second answer is definitely the cellular therapy. That means platelet-rich plasma or the mesenchymal stem cells or the commonly which called as the MNC cocktail in early mild to moderate cases depending upon the severity. Now, active chondrocyte means the chondrocytes which can proliferate. If they can proliferate, they will do their job. They will repair it beautifully well. They will make it very healthy. So one answer is by cellular therapy. That means the mesenchymal stem cell or PRP or MNC, and we are not able to discuss much in detail because we are just touching these topics here this evening. But definitely this is a different answer. But as the trials are not being done, so definitely we are not in a commanding phase. But definitely yes, we all orthopedic surgeons know that these growth factors which are being secreted by the platelet, which are being secreted by the mesenchymal stem cell, which are being secreted by the hematopoietic stem cells or the monocyte or any damn cells there, they have a aim to repair the things very well, and the repairing is what? The proliferation of the chondrocyte, the multiplication of the chondrocyte, that's so that they can become a healthy. So we all know, I think this will again touch that the mesenchymal stem cells are there in the synovial fluid. In the lecture today, we have a discussion that synovial they produce the synovial fluid. But what is a synovial? Synovial are nothing but these are the mesenchymal stem cells, which are present hooks and places, different places of the body. Now, exercises, by the brisk walking, means simply the stimulation of a synovial fluid. That means the cartilage which is there, which is present in the chondrocyte, which is present in the mesenchymal stem cell, which are being secreted by the platelet, which are being secreted by the mesenchymal stem cell, or any damn cells there, they have a aim to repair the things very well, and the repairing is what? The proliferation of the chondrogenic potential of the cartilage, or the stimulation of the progenitor cells, or the stimulation of the mesenchymal stem cells, or the stimulation of the synovial, or the stimulation of the progenitor cells to proliferate. That means a brisk walking only in the mild to moderate stage, where there is no mechanical derangement, where there's no other pathology. In that case, it is going to work. And that is the reason our professors, old professors, our teachers, and the yoga and all the things, if you correlate this thing in the cycle form, all the answers will be there. But again, lack of the evidence, as we are into the evidence-based medicine. So take-home messages would be PRP in early osteoarthritis may be useful for early osteoarthritic knee in a given situation. Mesenchymal stem cells may be of use for mild to moderate condition because they decrease their inflammatory cytokines which we want. They are basically the analgesic bullets inside the knees, and that is why with the brisk walking, as the endorphin has been increased, it has been estimated that the thickness of the cartilage also is being increased. And it has been very well reported in the medical fraternity, with the medical science now. And definitely what the result we are getting from any damn cellular therapy is the paracrine effect. Here are the few references. Thank you so much. Thanks a lot.
Thank you, Dr. Manish. There could not have been better explanation of how the stem cells work. Well, Manish, cortical injection into the subarticular tissue, does that help?
Definitely. So it is again the same answer as you have highlighted this evening, that the subchondral bone is the most important thing. Not only here, even the avascular necrosis head of the femur, lot of clinical trial has been done that subchondral bone needs a mesenchymal or cellular therapy or PRP injection at the same time, 100% marks given to it along with the cartilage. So it has to be given there also. But again, because of the lack of the evidences, we are not able to make it in a evidence-based medicine manner unless until the clinical trials have been done in our country.
But it has great possibilities. Now, talking about window of opportunity with your stem cells, what is your opinion? Because window of opportunity is provided by removing mechanical load, stopping destructive forces on damaged cartilage, and it reestablishes joint homeostasis where MSCs have been put at the sites of damage.
Perfect, sir.
Right. So thank you very much. And now may I invite again Dr. S.S. Amarnath from Bangalore for his presentation on nuclear synovial orthosis. Dr. Amarnath, please.
Thank you, Dr. Jha. Can I share my screen now?
Yeah.
Just a second. Right.
Wonderful. Thank you, sir. Thank you. I'm just going to be taking this. Yeah, great.
We should ask Manish also about osteoporosis. How this stem cell can help in the osteoporosis.
In the end, we will do that. Right.
Right, we are able to see the screen now, and this is going to be a quick fire round because it's going to be only a couple of minutes to talk about, and definitely. So the new term for a lot of young people and for the senior and the seasoned orthopedic surgeons probably who have not heard about this term is extremely important. Radiosynovial orthosis. RSO, simple terms, simple, very, very simple. And what is that? It is a simple term. RSO gives refer to a technique which is already there on the slide. I don't need to really read it, but I will just go on anyway. Now, we give into the joint a local application of a radioactive. It is not a dye. It could be, but it's a radioactive agent. But this is given in osteoarthritis. One, it is not just to relieve the pain nor the discomfort, but we need to improve the inflammation so that the patient who is receiving it gets a better, what shall I say, effect, pain-free, joint. So this is not a new technique, to tell you frankly. It's been there for a long time now. It's about 40 plus odd years now. Many of the orthopedic surgeons are not even born when this technique was stipulated. There are a few reasons why it did not take up in the big way in those days, because of the availability of the nuclear isotope, which was very, very restricted in many of the countries as well as in India. And we need to have a governmental, clearance to get those radioactive the agents into, because it's very highly radiating. So we have to be very careful in those things. Keeping that in mind, yes, back in the 60s, when DECELERATE talked about this entire thing, to restore the knee joint in a better way by injecting the radionucleotides into the joint to make it non-surgical, or probably a radiosynovectomy kind of a term which was nomenclated those days. And it was forgotten because of the availability of the centers in the country and the world as well. So let me run through that. Now, yes, the radiopharmaceutical industry has grown up in a massive way. As Dr. Jha mentioned earlier on, a PET, ordinary CT to PET CT to PET MRI, and a lot of things have been done. So keeping that in mind, what is that we use here? For larger joints, we have Atrium 90 and Rhenium and Erbium also available. But the majority of the joints which we talk about is into the knee joint today. So let us focus on the knee joint. Atrium 90 is the one which is being used in a big way. And what happens there? I mean, this colloidal injection causes the phagocytosis, which is already there, which Manish talked about a lot of things in the past, in his last few slides. And the changes which happened, what Abhay also talked about, in the condition, what happens with the pathogenesis, what Dilip talked. We try to give the injection, and when one injection is given, it forms a sclerosis or fibrosis. The synovial stroma, the villi will be affected, and then it gets devascularized, and then the cartilage becomes thicker and pain-free for them. It takes a few weeks to months for that to get the effect. And yes, this is going to be just a bird's eye view for you people. Basically, the dose is variation because of the joint involvement will be different. And again, in the knee joint, we talk about 185 mega or 5 curie atrium to be given. And in a year, those cannot be increased, because like in a hyaluronic acid or a steroid, people have given repeated injections. But here, we need to be very specific and not to repeat too many times. So there is being a very clear-cut understanding on that. Let us not take too much time there. Now, yeah, we talk about the dosage. We came there. 185 we talked about. So that is where the knee joint atrium dose will be coming to. And what happens? Can we give multiple joints? Both the knee joints or single uni or bilateral can be given. It can be, but again, we need to assess the dosage as well as the patient's body structure, and then talk about it. So with that in mind, yes, there could be good results. There may not be that so good results. There are a lot of reasons for that, but we need to make sure how we can differentiate it and take it forward. The second dose also can be given in about probably 8 to 10 months time. And many a times when the osteoarthritis starts, people also have injected into the cyst, and it has regressed very, beautifully there. So the side effects, yeah, like in any drug, no drug is safe. So every drug is a poison in the true sense of the term. Even this has some amount of side effects. Being what shall I say, injectable kind of a thing. So we need to be careful about the infection, make sure all the sterile precautions have been taken care. And then I don't think there's a major issue, but except some neoplasm has been documented, but we need to look into in a larger study. Contraindication, obviously, because the knee joint osteoarthritis is not limited to old age. younger people can come in. Even in pregnancy, people have seen this. So this particular injection cannot be given in pregnancy and lactation. So that's very, very clear-cut indication. And some of the conditions where we can indicate from rheumatoid arthritis, I know we are talking about osteoarthritis, because all these things can give us a secondary osteoarthritis. Hence, the list have been put here. So these are the kind of precursors where osteoarthritis of the knee can be seen. So this can be used. And special precaution with hemophilics, they should have a proper workup done. And now, the effect. We talk about how good is it. So naturally, we talk about the knee joint. 77% they have seen good results, and it's almost maintained that in the end of 2 years. So it is a very good thing to look into in the future. And definitely, there's a lot of study need to be done. Yes, there's going to be a lot of radiation comes into picture, so we need to be taking care of all those precautions, and the methods are also different, and how we're going to inject it and how we're going to dilute it. All those things have to be given. And one thing, as we talked about, any injection going into the joint can cause some amount of inflammation. And thankfully, unlike in hyaluronic acid, a steroid can be utilized to reduce the inflammation post radiation, or what we call it as radiosynovial orthosis. So that is the biggest thing. And the side effects we want to talk about, I think I'll leave it. It could be a simple infection. A joint infection is a very serious one. Simple, we have to be careful about. But we have to rule out the inflammatory response to infection. That has to be made very, very clear. That has to be differentiated. So that has to be worked out and clearly explained to the patient. And mind you, we have to have a proper counseling and consenting, and we need to have a regular follow-up so that patient gets a big, cheerleader for us. In the past, radiologists used to be doing all the works, the radio diagnosis. Today, thankfully, the radio diagnosis has been super specialized, so we don't need to worry about he or she being pulled in different directions. Thank you. Thank you. With this, I think I will probably end my slide. And thank you, Dr. Jha, and thank you, Shiva, Naveen, and everybody to give me a bird's eye view on the radio synovial orthosis, what we talk about. Hopefully, this should be able to give a precursor for to do the future studies. Thank you.
Right. Thank you, Dr. Amarnath, for making at least this word very popular, synovial orthosis. Now, as you have rightly said, that we have to have familiarity with this science, which has not been explored by we orthopedic surgeons. Many of us may not be knowing, but since the facilities are there at many centers in a metropolis, at few centers in larger cities, I think we orthopedic surgeons have to be conscious of using this modality of management of osteoarthritis, where there is activated synovitis. Well, there is a drawback that at one go, we have to have 10 patients clubbed together, because the nuclear material that comes is meant for being used in 10 joints. So thank you very much, Dr. Amarnath. Now, Dr. Manish Khanna, Professor Manish Khanna, are you there?
Sir.
Okay, now it is my turn. Can I have your permission?
Sir, please.
Okay. My cursor, I am not able to see my cursor. How do I go about it? Yes, now I get my cursor.
Showing the last slide first.
I will come to the first also when you are there. So friends, the whole subject of osteoarthritis has been discussed in the light of the changing trend of its pathogenesis, and hence a likely change in the trend of management. So let me embark upon what future holds. Well, friends, before I really talk about future, I was attending one of the Indian Orthopedic Association webinars, and there somebody said that steroids are not to be used. So let me first of all say that what are the various drugs which could be used by intra-articular route? Corticosteroids tops the list, hyaluronic acid, we have just now talked, and the other treatment modalities which are still in the stage of experimentation and has not got approval are TNF inhibitor, and mind you, very simple, capsaicin also has been found to be used intra-articularly. Topical use was existing for a long time. Intra-articular capsaicin injection has found to be useful, and it is said that the afferent nerve fibers within the joints, they get damaged, and hence the patient does not perceive it. The small molecules, their intra-articular use in the form of BNTA also has been used. Botulinum toxin, which normally is used for treatment in mainly the cerebral palsy patients, their intra-articular use have also been have achieved some success, but still is not recommended. Well, coming back to the topic of corticosteroids, I must tell that US FDA has approved corticosteroids for intra-articular injection, and they are in various forms: betamethasone acetate, dexamethasone, methylprednisolone, triamcinolone. Now, the intra-articular corticosteroid guidelines in osteoarthritis, they are not uniform recommendations. So for knee osteoarthritis, hip, hand osteoarthritis, if we take these three into consideration, American College of Rheumatology and Arthritis Foundation guidelines in 2019, only 2 years earlier, they strongly recommended for knee and also for hip, and conditionally recommended for hand. OARC guidelines, again from 2019, they conditionally recommended it for knee and did not mention about hip and hand. AAOS had inconclusive or limited evidence in 2013 for the knee joint, but in 2017, they strongly said it should be used in the hip joint. Now coming to the recent advances in the management of osteoarthritis, I will be highlighting 2 points: introduction of new therapeutic agent, and number 2, introduction of evolution of sophisticated drug delivery system. Now friends, WNT signaling pathway is a pathway which exists and stimulates production of catabolic proteases. This is implicated in matrix degradation. It modulates differentiation of osteoblasts and chondrocytes. Now, following consequences of long-term intra-articular glucocorticoid, evolution of small molecule inhibitor of WNT signaling pathway was developed, which deserves our attention. For quite some time, this particular drug, which is a WNT pathway inhibitor, was known by the eponym SM04690. But now it has a name. It still has not been marketed, but Loresivivint. Loresivivint is a WNT pathway inhibitor, and it has disease modifying possibility. Now, this particular drug, when used intra-articularly, might cause cartilage regeneration and protection from cartilage catabolism. So claims of significant difference in joint space width. Mind you, the standard of development of a DMOD drug is that if the drug can reduce or rather can increase the depth of the joint, that is to be approved. So here there is likely improvement in the joint space width. And as I had told you earlier, phase 2 trial is under process and will examine these things. Now, the second point that I wanted to highlight, that there has been introduction of evolution of sophisticated drug delivery system. Normally what happens when we inject a steroid into the joint, the effects they start fading away within 2 to 4 weeks. So to prolong the action of glucocorticoid, if at all it has to be used, introduction of new delivery system known as polymicrospheres. In short, it is known as PLGA, polylactic glycolic acid. So this technological advance in targeted delivery approach has been approved by FDA for knee osteoarthritis. It is not pending approval, it is already approved. So we are repurposing an older existing drug in the new format, which again had an eponym FX006, but now it has a name Gilreta. And this is nothing but an extended release formulation of synthetic triamcinolone acetonide, which is loaded on PLGA microspheres. This maintains concentration in the joint for several months after a single dose, and pain relief is greater up to 5 to 10 weeks. So, as I told you, degree of joint space narrowing, which we know also by the cartogram MRI, which says what is the depth of the articular cartilage. So it can have a prognostic value as well, because subsequent TKR is positively a possibility within 15 years. How? For each 1 degree rate of tibial cartilage loss, 20% increased risk of undergoing TKR within 4 years. So cartogram becomes a useful investigative tool where we can prognosticate. Now the third thing that I want to say, and I have said it earlier on a platform which was conducted by Dr. Amarnath on osteoarthritis, that though this will be something like a loud mouth speaking, but maybe in coming 50 years, joint replacement may be a thing of the past, because there are gene therapy mechanisms available, and gene therapy also is intra-articular, and this gene therapy could be cell-based, as Dr. Manish Khanna has already said, but this gene therapy also is also through the help of adenovirus. So this is initially developed for overcoming pharmacokinetic barriers, delivering biologics to the joints, great potential in treatment of diseases, including OA and definitely RA also. After 25 years of development, arthritis gene therapy is entering in clinical practice. US FDA in 2017 approved 3 new gene therapeutics, and South Korean Ministry of Food and Drug Safety approved first arthritis gene therapy, which goes by the name Invosa. Now, gene transfer and expression of gene in a joint by residing cells, therapeutic gene products synthesized indigenously and continually be synthesized for potentially extended period of time. As I was just now telling, that adeno-associated virus will has emerged as a popular vector for in vivo delivery. This virus is safe, effective, and less immunogenic. Now you can look into this, something like a spacecraft. This is the new gene, modified DNA, which is incorporated into the virus, is entering into the capsule, and finally the gene modifies the structures there inside the cell. Well, gene therapy, the intra-articular recombinant adenovirus transduces synovial lining cells as well as the chondrocytes throughout thickness of the articular cartilage. Considerable advantage in osteoarthritis, in which chondrocyte dysfunction has a key role. Invosa, we already know, is the 5th gene therapy approved product for anywhere in the world, and it is second for a non-lethal disease. Well, this genetic medicine for arthritis may have a future and likely to be widely available by middle of the next decade. Friends, coming to the 4th point, small molecules. Well, the idea that progression of osteoarthritis is results because of imbalance between catabolic and anabolic factors. Now, there is something known as ECM, extracellular matrix. Degradation of extracellular matrix underlies loss of cartilage tissue in osteoarthritis. Now, BNTA, which is an intra-articular format of small molecule, this stimulates expression of extracellular matrix components while simultaneously suppresses the inflammatory mediators. Intra-articular injection of BNTA also delays the disease progression. Well, friends, we can see we did not talk about parathormone, but this is also one drug which helps as an anti-resorb parathormone and other anti-resorptive drugs like strontium renylate, cathepsin K, and bisphosphonate, and they have their own path of action. And this is where osteoporosis is taken care of, what Dr. Dilip just now wanted to know. Now, coming to opioids, 2017, Yu et al. Said that there is a substantial risk and should be reserved only for patients not opting arthroplasty. So, limited role with eye on adverse effect must be seen. Now, friends, there is a silver lining in the medical management of osteoarthritis in sulfasalazine and small molecules. So sulfasalazine and tofacitinib, they work on the protein portion of the articular chondrocytes, and it has opened new vista in the management. The novel functional aspect of tofacitinib is that claims to promote cartilage extracellular matrix generation and increases cellular levels of adenosine known to have anti-inflammatory effect. Now, sulfasalazine inhibits tumor necrosis factor alpha expression, so may reduce secretion of inflammatory cytokine such as interleukin IL-8. IL-8 is in fact a small cytokine which goes by the name of chemokine also. It might suppress B cell function as well. Well, in short, sulfasalazine has antibacterial effect, anti-inflammatory effect, and immunomodulatory effect as well. Well, these have been talked about, and as I have told you, that US FDA and EMA says that approval of DMOAD requires inhibition of loss in knee or hip space, joint space width on plain radiograph with relevant symptomatic benefit. And here so many products can be seen which Dr. Raza has also talked about, which Dr. Elhens also talked about. NSAIDs, tramadol, duloxetine. Duloxetine is one drug which can be used in patients with persisting pain in spite of NSAID, and chondroitin. Well, other drugs we have already talked about, but here you will find colchicine, tranexamic acid, vitamin D, also hydroxychloroquine. Now, there are many drugs in the pipeline. Why have we thought of talking about osteoarthritis vis-a-vis the drugs that are in the pipeline? So if you look into them, that what are the various targets and what are the molecules, I will not read each one of them, but you can look at them, that so many are there in the pipeline. And the targets could be IL-1, TNF-alpha, toll-like receptor, other targets. And nerve growth factor is also one very important target on which tanezumab works. So even COX-2 and T2M, including metformin, is one drug which is likely to be effective. Similarly, statins, all the various statins are also being worked. And friends, I would like to conclude that what future holds are in the already proved in the hands of development of new therapeutic agent, Loresivivint, which is a WNT pathway inhibitor, the introduction of evolution of sophisticated drug delivery system like PLGA, extended release formulation of FX006, Giloreta, which is synthetic triamcinolone, intra-articular gene therapy, is small molecules targeting bone remodeling, also raises hope for treating osteoporosis and osteoarthritis by regenerating both bone and articular cartilage. And last but not the least, inhibitor of MMP13 also is equally important and is likely to be topping the list of the drugs treating osteoarthritis. Friends, I will like to end with a quote which was there in one of the editorials written by Charles J. Malmud from Cleveland, Ohio, and it was written in the journal Future Drug Discovery in 2019. He says, however, I believe at this, that one thing is certain. That one thing is certain. What? It was previously proposed that since many of the cellular events characteristic of rheumatoid arthritis overlap at some time with those in OA, which we have talked in this webinar, why not use those accumulated successes in the drug therapy of rheumatoid arthritis to treat osteoarthritis? I will read it once again. One thing is certain, it was previously proposed that since many of the cellular events characteristic of rheumatoid arthritis overlap at some time with those in osteoarthritis patients, why not use those accumulated successes in the drug therapy of rheumatoid arthritis to treat osteoarthritis? Friends, this was the stimulus to have this webinar, and I firmly hope that we have not talked anything which did not have a merit. We have talked about TNF-alpha inhibitors, but simultaneously we have said that none of the series TNF-alpha inhibitors have been successful till date, and these TNF inhibitors have been used intra-articularly. And any DMODs which are being developed, they will have to be used intra-articularly because the systemic effects may not allow their constant use. Thank you, friends. Thank you very much. Dr. Manish.
Thank you so much, sir, for a wonderful presentation, giving the insight of everything which is still in pipeline. Thank you so much.
Right, friends. Now,
So you can stop sharing your screen.
I am going to do that. My cursor is lost. Okay. So in the meantime, since the video audio is working, I am trying to close it. So let us discuss about various inputs or various questions. Are there any questions, doctor?
So there's no question in the chat box actually.
Oh, okay, may not be a question. So Dr. Dilip, you wanted to say something. Dr. Dilip.
Yeah. Actually, they partly you have given the answer. That is why I'm stopping. Actually, I don't like to ask Manish about that thing. But
Okay.
one thing is important, that it is a disease. Not only the bone and the cartilage, but all the tissues around the joint are affected, including the muscle.
I can see Dr. Shiv Shankar, President of Indian Orthopedic Association.
Is they come here? Yeah.
Yes.
I am there right from the beginning. I've been listening.
Okay.
I heard your lecture also, Majumdar sir.
You will have 100 years of life, you know. We are thinking of you, Shiv Shankar.
Yes, thank you.
We are thinking of you.
Good evening, sir.
Yes.
And you just appeared, eh? So, good evening, Shiv Shankar.
Good evening.
Your comments, valued comments.
Definitely, this is what the regular osteoarthritis we were dealing earlier. It seems to be very superficial when I hear this webinar that everything has gone back to the level of cellular, microcellular, and also it appears sometimes like it is whether I am attending a osteoarthritis webinar or a rheumatology webinar. So definitely,
I must tell you, sir, this is your rheumatology subcommittee doing justice with this subject.
That's what I am telling. So definitely there is so many things which are happening, and glad to know there are so many newer drugs and medicines are in the pipeline which will be available for the benefit of us. Hopefully we'll have someday some vaccine to prevent, we probably will have some genes to modify the disease before this happens in a potentially a prone patient or a prone candidate, or we'll have a magic vaccine probably for this to prevent this osteoarthritis in future. Thank you very much. I must congratulate the enthusiasm with which you have been conducting and also sharing slides in between the presentations to add value to the presentation. Thank you very much, sir.
Right,
except the first talk, I was there all throughout. I joined while Dr. Majumdar was talking.
From our inner conscience, we were definitely missing you, and we were thinking that whole exercise has gone futile since you are not there. I was very happy to see that you were attending it. Any questions are there? Dr. Manish?
Chat box.
Chat box is empty for reason that our doctors have started.
Also has to ask if there is any questions on the Artho TV or IOA TV channel. YouTube channel. Okay.
Okay. Dr. Yogesh, are you there?
No, is.
Okay.
Nothing. Yogesh has signed off.
Okay, does not matter. He was sitting for quite some time. Yes, you please, Dr. Amarnath.
Thank you. I think, see, one with the cellular therapy, what Manish talked about, and then you also rightly mentioned about the delivery system. See, now the beautiful, invention of the delivery system, it's one of the best things. Unfortunately, the pandemic has come in, obviously, so I'll not comment on that. But the best delivery system is to put a package onto the virus and inject into the body wherever you want. And that creates history. And that delivery system, as I rightly said, Dr. Jha, the adenovirus virus has been picked up with a very, very simple, non-infective, and a huge amount of multiplying, what shall I say, the ability of the virus and to subside the kind of target cells which is going to be given and the target what it's supposed to do, does it fantastically. So no wonder, I think the future definitely is going to be there. As Shivshankar said, the microcellular DNA level, and we are at it. It's going to be in a big way. And it's going to be in a big way, the surgical versus non-surgical and, the right choice of the patients comes into picture. And future is something different. I mean, we're talking digital today and instead of physical. Similarly, the kind of changes that we are going to see in the therapy is going to be humongous. And this delivery system module of adenovirus is going to be here for everything what we're going to do. I think Manish can comment or anybody.
Before that, I want to add one thing. Dr. Amarnath, you had drawn my attention that in Western countries, there is a combination of prilocaine along with hyaluronic acid available in the market. And they say that lidocaine or other anesthetic agents, they do not form a stable component with hyaluronic acid. This is one which makes a stable component, and there is an excipient as well. So that combination is tremendously in use. Your comments on this particular product, lidocaine plus.
Yeah. So in fact, I will not bring in the brand name and things like it's already available. And there are a few of the trade partners who are looking into that in a big way. We have discussed in a massive way in the last 6 months to 8 months about this product to coming to India. And obviously with the pandemic, a lot of files have been kept in, behind for us to get it through. So it is going to be coming in probably 2022, in another few months time down the line. Hopefully we should be able to bring it out in India. So that is one thing which is going to be one of the game changer for us now. And second thing, even this is also a very high, molecular weight substance. And the beauty of this is if we don't have to give a large amount, like 6 ml into a joint, it comes in 2 ml and 1 ml with prilocaine. So we can use it in the smaller joints as well. So even for the knee joint, 2 ml is sufficient and it does magic. We have to say, for example, now any given hyaluronic acid, be it the originator molecule or the biosimilar, they take about 6 to 8 weeks to act. But here, what happens, it's almost 24 hours to 48 hours. They get a beautiful relief of pain, which is fantastic. And the hyaluronic acid, which is high molecular weight, I think it's more than 10 or 20, I think 10 or 15,000 Daltons. So that's going to be very, very good. And it is going to be effective for the next 1 year, they say, 8 to 10 months, or maybe 1 year, because of the plasma half-life is much longer than the existing ones. So the dosage is small, and it can be used in the smaller joints as well. And the frequency is going to be less, and it's almost immediate effect because of the anesthetic which is there. And the prilocaine also has been given on a longer, chain, so that anesthesia effect or the analgesic effect goes longer. This is my comment, sir. And we will be getting it. We will be coming out soon on that.
Right. Talking about one more product, calcitonin, which has been withdrawn from the Western markets, Western world markets. It is again has come back, and the oral use, not the nasal use, oral use of calcitonin for treatment of osteoarthritis has been brought back. So this drug is to be looked for as a future utility drug. Well, Dr. Raja, yes.
In fact, Dr. Abhay mentioned about the study which was done for the calcitonin. We were using calcitonin for injections in the past. I mean, it was banned across the world, including India, obviously. Now the nasal has been restricted. Again, they were using right, left, center. But again, due to the carcinogenic effect, it was withheld. Now, with the study coming into the oral thing, what you rightly said and what Dr. Abhay also mentioned about, it's a different formulation altogether, and then we haven't seen that kind of challenges there.
Right.
I think Abhay or Raja can talk on that probably.
Dr. Raja, any comments on this calcitonin and also on intra-articular capsaicin injection, which seems to have a very good popularity now and is rather advocacy now that it also works well.
But the problem with all this osteoarthritis research and the outcome is there's a big overlap between the placebo and the drugs. So all these interventions are limited because even with the placebo, you are able to achieve better results. So somebody intervened in between the sets. Synvis 1 was working wonderfully, but the international recommendation is against the use of hyaluronic acid only for early symptomatic patients. So there's a lot of overlap between placebo and these therapeutic interventions. So need more research and further follow-up into these drugs.
Right. Talking about placebo, this is one thing that which I keep on talking about, that any trial is compared with a placebo, and then placebo also gives sometimes comparable results. So psyche becomes so very much important. Any comments on this placebo comparative therapeutic trial? Dr. Shivsankar, we were talking about the use of placebo in various trials. And to our utter surprise, many a times the placebo also gives either comparable or somewhat comparable results. So any comments on use of placebo?
See, two things. One, we should know. See, many of it's just marginally better than something else. So everybody want to sell their product and they come with research saying that it's equivalent to placebo or slightly better than placebo. It is our judgment, we should use it. And at present, I feel that this is what a webinars I'm looking at is for general orthopedic surgeons, and it is going through a very core specialty area. So I think it is too much at present. That's what I feel. So we are overshot by 35 minutes.
Okay, so we will close it now.
Yes.
And vote of thanks is to be.
Let me start thanking, because I was not there initially. Let me start the person who is missing, Dr. Yogesh Kamath, then Dr. Amarnath, Dr. Kamlesh Tiwari, our subcommittee chairman. Thank you, Kamlesh ji. I missed you at Ranchi. And Dr. Dilip Majumdar, president of IOA, Dhanshekar Raja from Coimbatore, Abhay Alans from Jodhpur, Professor Manish Khanna from IORA, then IOATV team, Ashok Sham, and IOATV team, Dr. Shamshal Huda, for all the help. So I thank everybody for this wonderful webinar. Thank you. Thank you.
Thank you very much. We are honored by your presence even in the end.
Thank you, sir.
Thank you very much. Thank you.
Raja, okay.
You can stop.
Thank you very much.
Ashok, you can stop live streaming.
So Raja should convey to Deen Dayal.
Yes.
Samsul?
Deen Dayal is there in Coimbatore.
Yes.
You convey my regards to him.
Sure,
Dr.
sure.
Huda, you can stop the live streaming. Dr. Huda, are you there?
And
I'll be there tomorrow by this.
Yeah, tomorrow we'll be
in
coming
Kolkata.
to our place. Shivsankar.
Yes, tomorrow evening this time I'll be here with you. Yes.
No, tomorrow you will be here, na, Shivsankar.
Yeah, this time I'll be in your office. Don't worry. Bye.
Now?
Right.
Okay.
His connection is slow, so it will take some time.
No, Raja, you must convey to two persons. Huh?
Sure.
One is Deen Dayal and another is that spine fellow. What is that name? Tall fellow?
Ajay Prasad Shetty.
No, spine fellow. He was co-examining with you. Huh?
Ajay Shetty, you are telling?
No, in Coimbatore. Roga Hospital.
Ajay and Rishi are there. Fine.
No, one that his wife is a pediatrician or something. Is a DNB examiner, Raja?
Yes.
He's also a DNB examiner.
So, Dr. Jha, thank you. It's been a real pleasure to have been associated and share some thoughts and then learn a lot of things from all the people.
No, it is a revolutionary thing, you know.
Yeah.
Actually, I wonder that if these developments come, then where will we stand?
So friends, this is going to be the last of the series.
Okay.
And we are not going to have any further webinars because now this is the month of September, October, November, and then you have conference.
So we'll meet in Goa.
Yes, we will meet in Goa, and I'm thankful to all the faculty members who are present, all the other faculty members who are not present today. Tremendous support I had of everybody. I'm so very grateful. Thank you.
Dr. Jha,